this is the third of a series of sessions that we've been making within the Insights 2022 about decision making for your kind of, around population, and this idea of we've been building up to this. This is the big one. This is the one that you've all the rest were meaningless without this really exciting one that you will hear from, where you hear from Richard, Jack, and Leslie. And it builds off of the very first presentations that we had from Alistair McClellan and so David Nicholson, where they were talking about system working and how people can get together. And as promised, we have an example of some of the work that's being led by Jack Ettinger at the Health Economics Unit, and how he's working with 5 ICSs across the country, 4 ICSs, 1 place, across the country, with an amazing piece of work on how to try and bind people together in some of the decision making. So it's wonderful that you can join us today, and I would love to be your host throughout it all, but I have to, in trademark poor planning, this is what I do. If the wonderful Rukia and people like that aren't here to organize me, I'm at the Karolinska Institute in Sweden, in Stockholm, with the World Bank, talking exactly about the same topic, where we've had colleagues from Sweden, Poland, Moldova, Harvard in the US, and McGill, all talking about system working. And we're, and it's great to see that some of the work that the guys are doing today, that some of the work that Jack, Richard, Leslie are leading, is actually at the very, very forefront of this kind of work going forward. So I have to leave about halfway through, but the wonderful and amazing Wayne Smith, our chief economist, who much better understands this than I do, will be working with you to make sure that it runs smoothly. So, as always with Insight 2022, please introduce yourself in the chat. So your name, where you come from. It helps us make these meetings and tailor these meetings to better meet our audience's needs. So it'll be wonderful to have that information as it kind of goes through. And as always, we'd love to hear your questions and your comments. So if you get the opportunity and some of the exciting stuff you hear from Richard, Jack, and Leslie, please ask your questions. We're going to save them to the end. And Jack, Wayne will be working with you to kind of cover your questions. If he leaves any out, post it again. Don't let him get away with I'm not asking your question if it hasn't been answered. And then you'll be able to kind of hopefully build up from there. We've got a whole hour and 45 today. We may not use it all, but what we wanted to do is make sure there was enough time for you guys to be able to really understand and really ask this crucial question of, not just how we go about doing stuff. I think that for a long time we've talked about how we will approach working together as a system, but actually some of the pragmatic challenges that you will be facing as we kind of go through. So thank you ever so much. And so I will now ask each of our speakers to introduce themselves briefly, and Wayne will remind you of the topics for each of those, but I'll go to Richard first, then to Jack, then to Leslie, and then we can kick off from there.
And thanks for inviting me to the session and for contributing. So I'm Dr. Richard Mendelsohn. I'm a local GP in South Birmingham. So I work in the Birmingham Solihull Integrated Care System, and I'm an Associate Medical Director within the CMO Directorate.
Thank you. Jack.
Hello, yes, I'm Jack. I'm a health economist at the Health Economics Unit. I join you today from my wardrobe. Hello, everyone.
Nearly as glamorous as the University at Stockholm. We send you to the best possible places, Jack. Over to you, Leslie.
Hi, I'm Leslie Terry. I'm Head of Integration at Universities Hospitals, Coventry and Warwickshire. I'm part of the strategy team there, and I've been working with Andy and Jack and the team on trying out this new methodology, focusing on the COPD pathway in Coventry.
Thank you ever so much. And today the guys will be covering the challenges behind this kind of system level thinking. And I think it's something that we've been thinking about a lot. And I'm very lucky to sit on the council of the HFMA, the Healthcare Financial Management Association. And what we were asking was, how do people
when we make decisions, how do we move resources to be able to make sure that those decisions are enacted? How do we make that action happen? And so that was one of the kind of the key elements that led us to starting this program. And then as we were talking to systems across the Midlands and beyond, we had a huge amount of support. So again, it's people like Leslie and Richard who had the vision to try this approach. You know, the approach that we'll talk about has been around for a long time. It's freely available to the NHS, and Jack will cover the technical and social details of that later on. But so hopefully it'll be a really exciting session. Remember to introduce yourselves, remember to ask the questions, and I will now pass over to Richard to talk about why would we restart doing this kind of work in the first place.
Thank you, Andy. So yes, I work, as I said, in Birmingham Solihull, and I guess like a lot of systems, we're really just starting our journey of integration. It's clear that during the preparatory work, going from a CCG to an ICB, we were able to use that time and create a set of principles, working principles, the documents that we needed to start to bind ourselves together at a system level, which is not easy if people know Birmingham and Solihull. And we think that we have a vision. We have 6 key challenges, and I'd like to highlight these because one of them is about ensuring investments and focus on areas of greatest impact. I mean, there are 6 in all, so we want to make sure that the citizen's voice shapes services. We want to make sure that we've got clear accountability for delivery, that decisions are locally driven, that we're enabling this the advantages of an integrated care system where we've got cross-organizational planning and care delivery and supporting innovation to accelerate change. But I think having set ourselves a challenge of ensuring investments focus on the areas of greatest impact, actually how you do that is not particularly clear or straightforward at this point. So we're going through a learning process. We also have some transformation priorities that underpin integrated neighbourhood teams, which are important to us, about the use of technology, making sure we've got the right workforce, we're sorting out estates, we're tackling inequalities, and we're using excellence to standardised care. We've had a big boundary change, which I think is a complicating factor for us. So we've brought in the west side of the city of Birmingham into the integrated care board. So we've got 2 levels of integration to do. One kind of geographical with a whole new patch that we've never had before. When we were the old Birmingham Solihull CCG, we'd already made a change from 3 CCGs into 1. We're also, like I think other systems, setting up an integrated care partnership. And I have to say, I think the integrated care board is ahead of the partnership in terms of organizational maturity. And a lot of the structures that we're setting up are still settling down, and particularly I think this journey to a strategic commissioner and what that actually means. We know that we're going to have to think about bringing in the extension to the co-commissioning role, so taking responsibility for additional primary care providers and resources, and the extending the pathway from a number, not just general practice, but our other primary care providers through the whole of the pathway. Will be next year in a shadow year around specialised services. So there's a whole gearing up of getting ourselves ready to extend the pathway further that we're going to think about, because it will include specialised services. And finally, there's and I presume most systems are going through this, a sort of delegatory function around provider collaboratives and what we call integrator roles. And so I think organisationally, in terms of structure, we're becoming more complex, not less complex. And I haven't even mentioned place. So I know that Andy, you talked about one place. We're still setting up our places and what that means and how to integrate place, Birmingham and Solihull, into our decision-making processes. And I think, like most integrated care systems, we've got the starts of our frameworks in place, so an inception framework and an operating framework. So although we have a single now strategic governance process, oversight and accountability through the ICS, we're starting to think about how you bring in local direction setting at place through these service integrators and community integrators alongside strategic decision making. And I think this is where this session starts to fit in about what tool can you use, what language can you develop at the ICB board level for system-wide investment in technology and the workforce and estates. But also, and interestingly, I don't know whether you have this in other systems, we've created something called the Fairer Futures Fund, a sizable amount of money for the voluntary sector to work alongside place to begin to tackle some of the long-standing health and inequality issues that we've got. At the same time, we're setting up system level approaches to a care management approach, be that community transformation, urgent and elective care, maternity, long-term conditions, something I'm particularly involved in as part of my role as population health management, long-term conditions and preventions. So I'd say at the moment, the state of play is this, that we are, we don't quite have the traditional investment round that we used to, the cold commissioning round. What we've got is an investment committee and a prioritization process that is, I would say, linked to and highly dependent on the work that we've done in the previous CCGs. And that's largely for the managed introduction of the new at a system level. Some of the things we've talked about, technology. The last thing that went to the investment committee was continuous glucose monitoring. And I'm sure systems are all, having to deal with the new technologies that are coming along. But what we yet to really get into is how do we manage the understanding between all our partners in the integrated care partnership? And I'm talking right across the board, as Andy talked about, from voluntary sector, from our patients, from our population to all our providers, local authority, as well as on the NHS side. And how do we understand that, manage that kind of what value means? And how do we get to a point where we're clear on what's actually worth spending the next pound in? What's worth investing in? How do we understand our best buys within pathways as well as the new? So I think the new, we've kind of made a start, but I think the prize for me is what's within pathways, because there's a lot of money tied up with pathways. Yes, we get additional investment, but the bulk of money is in these existing pathways. And I have to say, we've not even started to have a conversation in what this might be old-fashioned terminology in terms of program budgeting. So are we going to be moving as a system money between I've mentioned maternity, urgent emergency care or cancer, or long-term conditions, or other client groups, children? And I think this is a very difficult thing to do, and we're hoping I'm going to learn a lot from listening to the comments and the questions. So I think, I'm not sure at this point, but I think we will get there. Our challenge is, can we kind of transition from just an understanding of this total spend that we've got across a pathway and have that conversation between budgets and within budgets, and how do we do that? So we would see this as part of our maturing and a journey that we have to go on to have that conversation, to understand how collectively we appreciate what benefit and value means, and start to have the debate, because I don't think as we get into this, we'll start from a point where we actually all agree.
Thank you ever so much, Richard. And of course, it always brings great delight to my heart and warms my cockles to hear program budgeting and marginal analysis. I'm sure for everybody else, they may not get quite as excited as me, and I think that and what we'll hear next from Jack about some of the approaches that we're taking, or the approach that Jack is taking for this work, builds on some of that excitement. So please, any questions for Richard? For those of you also right now, I'm sitting in systems, places, primary care networks who are facing similar challenges. It'd be great to hear from you, and to be able to kind of have this kind of discussion at the end about how we work together about this, because say this isn't a problem just for us in England, it's a challenge for everyone across the world, as we're hearing today at Karolinska, but and how we find this common goal, this common kind of value that all of us share as we're moving forwards. So Jack, I will pass over to you so we can better understand the program that you've put together working with Richard and Leslie.
Brilliant, thank you, Andy, and thank you, Richard. I think especially, well, hopefully what I'll say will speak to a lot of the points you just raised, and I think particularly around that vision of clear accountability, locally driven decisions, enabling integrated working. There are techniques that you can use to help do these things, one of which I will go through today. So hopefully, oh, I've got to press share. There we go. Hopefully you can all see this. So why do we need to do all of this anyway? Why is everyone at the World Banking Karolinska talking about this issue? And that's because there's a problem, fundamental problem that all public services face. That is, there's a near unlimited wants and needs for our services, but we only have limited resources, which means we're never going to be able to meet everyone's needs. There are scarce resources. This means we have to inevitably make choices. And they can be made explicitly, so through prioritization processes, like Richard hinted at, or implicitly. If you decide to spend £1 million on a surgical robot, that's £1 million you don't have to spend on other things. We can't avoid making this choice, essentially. And at the HEU and elsewhere, one principle that can really help think about, well, given that we need to make this choice, where do we spend our money to drive value, is this principle of allocative efficiency. So allocative efficiency is an economics term. Other forms of efficiency are available, and it's all about doing the right amount of the right things. It's about maximizing the value or benefit that you get from a given set of resources. And this is our attempt to sort of try and conceptualize this. There are 4 things you can spend your money on to improve health. So you've got clinical care, behaviors, social determinants of health and the environment. And we in integrated care systems can twiddle these dials, change the amount of resource we give to each one in order to give us the biggest heart possible, maximize the health of our population. But how do you put that principle into practice? How do you operationalize it? There's various different techniques and ways available. Anyone who's done a capital business case for DHSC and the Treasury will have done a cost benefit analysis. That's the Treasury's way of determining across transport, education, health, etc., where should the Treasury spend its money in order to get the best return on investment. At the Health Economics Unit, we're doing a big program of work looking at this method, the socio-technical allocation of resources method, working with Richard and Leslie and others, some of whom are on this call, hello, to look at the allocative efficiency of the COPD pathway. Why are we so keen on this method? There's a couple of reasons. First, it's really easy to understand and can make use of information that's readily available to ICSs. Also, you don't need to have a PhD in health economics to be able to do it. Yes, there's some principles you've got to get your head around, but broadly it's relatively simple and therefore scalable. So we think this is something that you guys in your systems can do yourself. So what is STAR? What is socio-technical allocation of resources? It's a structured and transparent way of setting priorities through synthesizing the views of key stakeholders and using the best available data to create visual models of the decision problem at hand. And it's formed equally of these two parts: a socio part, which involves getting all the relevant stakeholders in a room and helping them to reach consensus and align priorities, and a technical part, which involves creating visual models based in health economics principles. And I think, Richard, you mentioned that, you know, what does value mean? How can you drive value? What's great about STAR is you can incorporate multiple criteria into this framework if you so wish. I won't speak about that today, but you can expand what you mean by value if you need. So I'm going to talk to you about the technical bit first before going into the sort of socio element. And the technical bit revolves around triangles. Who'd have thought my GCSE in geometry would have been of any use? But there we go. So what you do is, given the particular decision problem at hand, all of the interventions within that problem you create a triangle for, and the triangle is made up of costs on the x-axis and population health gain on the y-axis. And population health gain is a calculation of the number of people who would benefit from that intervention and the benefit in terms of health gain that they would receive. And I won't talk about it today. There's various different ways of calculating that health gain that you can use. All of them have pros and cons. And what you get is triangles that look like the ones on the right of your screen. So some are very wide, they represent low value for money, and some are very high, they represent high value for money. And if you're looking at a particular pathway, what you do is you plot all of the elements of the pathway on a graph like this, with the ones with the high value down here on the left-hand side, going through to the low value ones on the right-hand side. And this clearly shows you where you're getting the best bang for your buck in that particular pathway. So here you can see this is an example looking at a falls pathway. So from, you know, people falling over. And you can see 50% almost of the spend of the value is driven by hospital admissions, but over 90% of the total spend goes on hospital admissions. And you can see this is a really clear and visual way of representing the problem, and can help to start facilitate conversations about, well, actually, what if we just gave an extra 10 grand to vision assessment and referrals? What would that change the pathway? How would that change the pathway? And what you can then get is a graph that looks like this. So you've got your current pathway there, and you've got, okay, we're going to do this to change it. This is what the improved pathway could look like in terms of value. It's a really clear visual tool that you can then use to start writing business cases, and also just to determine which of the multiple things you could do should you do. So that's one way of doing it. There's another approach you can take, which would work really well for some of the things Richard said, like the Fairer Futures Fund, called a portfolio approach. And this is an example from the Isle of Wight, where what they did is, instead of looking at a pathway, look at a portfolio of investments that the back in the day, the SDP could invest in, create those triangles. So each of these aren't from one pathway. Some are in mental health, some are in children and young people services, some are in cancer, etc. Create all the triangles. They decided this year they had £1 million to spend. So they set the budget constraint there and invested in everything to the left-hand side of that. So idea being they're investing in the things which will maximize the value from that investment. So that's the technical part. Why wouldn't you just give some data to your analysts and send them away to create those graphs and pump out the results for you? The reason is that collaboration is really hard. And in order for the decisions to stick, you need to get everyone to agree on what they are, especially when you're talking about potentially moving money between different organizations. And this is from a paper by Alderwick et al., which sets out why this kind of collaboration is really difficult. People have different organizations have different motivations, purposes, different outcomes they want to achieve. You need really well developed relationships and cultures to be able to do this kind of collaboration, which involves lots of trust. I heard a really good phrase, I think it's a Dutch phrase the other day, which is trust comes in on foot but leaves on a horse. As well as lots of other factors which make decision making based on collaboration really hard. I think one good example of this is if you're looking to share healthcare and public health budgets, the outcomes that public health consultants would be interested in would differ from healthcare consultants. So an example might be stopping someone smoking in schools. That is unarguably a brilliant public health intervention to invest in. But when you start putting that in the sort of framework of what healthcare is interested in, well, stopping someone smoking when they're 15 might mean they don't develop chronic respiratory diseases when they're 40 or 50. So you've got to wait 30, 40 years to reap the benefit of that investment. So it can be really hard to align the goals of different organizations for good reasons. And that's why STAR really focuses quite hard on the social elements of the process, which involves bringing together the key perspectives and experiences of the stakeholders across the whole pathway. So in the decision conferences we've been running, we've had patients, public health consultants, program managers, people who run smoking cessation services, more and more medicines optimization people, pharmacists, GPs, all coming together to help make these decisions. And we do this around something called decision conferences. So this is a picture of us in Northamptonshire. You can see how engaged everyone is, no one asleep. And this is a way of helping a group of key players to resolve important issues by working together. And the key is there's an impartial facilitator who's there to sort of bring the conversation along. And yeah, in the decision conferences, the real key is reaching a consensus. You can help to align people's views around a particular problem and reach consensus. So yes, that's the sort of key bits of the process. I think now I'm handing over to Leslie, who's going to speak from her experiences of once we finish this process, what Leslie and co will plan to do with it.
Thanks very much for that, Jack. That was really interesting, and Jack's and the rest of his team has done some amazing work rolling out STAR across the sort of 4 ICSs and one place, which Leslie will give you tell you a bit more about her experience of working with Jack and how they sort of roll out STAR in Coventry. And we get to some questions after. So Leslie.
Thank you, Wayne. And Jack, I think you're going to drive the slides for me. That's great. So I'm going to talk about the experience we had, or are having, I should say, because we're in the middle of it, of the STAR methodology in Coventry. But what I also want to talk about is the wider question that Richard alluded to in his presentation, which is, how do we make smarter decisions on spending in the NHS? Which you also could say, how do we make decisions on spending in the NHS in this new world of ICSs? Because if you listen to what Richard is saying, there are a lot of questions. We are now in a very complicated world, and we have a new way of working together. There's new people in the mix. We have a big responsibility to make sure that we're spending public finances to get the best benefits for our populations, our diverse populations whose needs are met by a diverse range of stakeholders. So this is a very new place that we find ourselves in, and there isn't a clear, there's no playbook on this. There's no methodology. It's not like, okay, we use the traditional commissioning cycles and we write business cases for additional activity and we get given extra money and then we deliver more capacity. It's not like that anymore. So we have a challenge and we have a lot of questions to ask ourselves around what new techniques and methodologies and approaches can we use to try and make decisions. So Jack, if you could pop on to the next slide, please. Cool. Okay, so Richard spoke about some of the key challenges impacting on decision making at that ICB level. So that's a kind of a whole system level, just in case there's people here who aren't familiar with the ICS, ICB. And then usually within an ICS, you'll have a number of places, which breaks it down to a kind of smaller, more locality focused area. So I'm going to talk about Coventry Place, which is the population of Coventry City, more or less, about 350,000 people. And I'll take you through a case study about a COPD program that we had in Coventry Place and how we use STAR, just to bring some of the decision-making challenges to life. So we agreed in Coventry, as will be the case in many of your localities, that COPD, improving NHS COPD services is a real priority for us. High prevalence of COPD in our population could do better on outcomes and access. So we set about developing a case for change for a new model of care that would reach more people and deliver better outcomes. I'm not going to go into the detail of our proposed future model because anyone who knows anything about healthcare will already guess that it involves investment in prevention, proactive community-based care, patient peer support, and a focus on keeping people well managed and away from emergency hospital admissions. Every aspiring long-term condition model in the country will be the same. It makes good clinical sense and it aims to improve overall health and well-being of people at risk of developing COPD, insert diabetes, insert heart failure, insert cardiovascular disease, and those living with those conditions. So our model was clinically led, it was informed by patients, it was based on evidence, and we can be assured that it will, if we were to deliver this model, it'll definitely improve access and deliver better outcomes for patients. Nobody will disagree that these are the right things to do for patients. The people who are accountable for making decisions on how to spend money will also agree these are the right things to do for our population, but providing better care to more people costs more money. It's a fact, okay? And in the good old days of, payment by results, we would say, we've got a problem with waiting times and we're not meeting these guidelines. So commissioners, can you please pay for some additional activity? We'll hire some more nurses and doctors and then we'll deliver more service. That's how it used to be. But in the current financial climate, we don't easily have access to additional funding. So we weren't able to make a decision to progress our new model of COPD care in Coventry. We couldn't move on forwards on that because there was no way to fund it. Okay. And that is a real life situation that many of us in NHS and social care and other organisations up and down the country are grappling with at the moment. We know what good looks like. We know what we want to deliver, but how are we going to fund it? Okay, so we have to ask ourselves as places, as ICSs or any other health economy, what other information do we need to support decision-making on investment in health and social care? And could you go to the next slide, please, Jack? There we go. Now, this diagram, I mean, I have a love-hate relationship with this diagram because this is about the quintuple aims, not just one aim, 5 aims of population health management, or really everything that we're trying to do in the health sector. So we are, this diagram to me is the crux of our challenge, okay? Our aim is to improve health and well-being, improve patient and staff experience of care, and address health inequalities. That's what we're here for. That's why we work in the NHS. That bit is actually quite easy to design because, you know, we can come up with, you know, clinicians and patients can tell you what good looks like. We can get a group of clinicians and patients in a room and come up with a really good model. The hard part is balancing that with the need to do more with the same. So the need to make sure that we are spending public money as efficiently as possible, that we're getting value for money out of every public pound spent. And actually, when you factor in growth in demand, so growth in the population and growth in the demand of what we deliver to the population, what you're really saying there is you've got to do all this with less money. And that's where it gets very tricky, because when you're working with NHS or social care or third sector teams, most people are coming from a place of feeling that their baseline capacity is under-resourced to begin with. It's very difficult to work with a group of clinicians or anyone delivering services and say, let's come up with a new model, but you can't spend any more money. It's, you know, of course there is waste in the system. Of course there are things that we are doing that we could do more efficiently, absolutely. But the reality is a lot of our services haven't been invested in for years. So I can't sit in front of a team of 3 heart failure nurses and say, you need to see 30% more patients and just work harder. That's just not going to cut it either. So that's why I say I have a love-hate relationship with this diagram, because I absolutely believe in what it says, but delivering it is actually quite challenging. And that is the real challenge that we need to face up to at the moment. Okay, next slide, please, Jack. So if prevention is better and it's cheaper, we think it's cheaper than cure, why is it so hard to move the money around? You know, we're starting to understand that some of the lower cost interventions might actually add more value than higher cost interventions. We all understand and believe in having more of a focus on prevention and proactive care so that less people end up in hospital, which costs lots of money. So why don't we just do that? Why don't we just take money out of hospitals and invest it into community groups, smoking cessation, patient self-management? Okay, there's a number of factors why it's not actually that easy to make some of that change happen. So, unmet need. The better your services are, the more capacity you build, the more people you reach. Those people then require your input. So it's really great that you're now addressing the needs of all of the people out there with undiagnosed diabetes, for example, or COPD. That's a really good thing for health. But that costs money, because now I have to provide medication to you, I have to give you an annual review, I have to look after your needs. So your population of patients who you're looking after has grown. And also, and this is a really tricky point, the better you look after people, especially in long-term conditions, people survive longer, which is great, because that's the whole point of what we're trying to do. We're trying to improve the health and well-being of our patients. That's great. But now I've got an even bigger population of people that I need to look after, because people are living for longer and they're surviving for longer, and I need to look after those people. And then they'll go on to develop more multimorbidities. Now that's an ethical question, right? And that doesn't feel very good. But from a purely financial point of view, I'm actually going to spend more money, okay? That's not something that's nice to talk about, but that's a financial reality of this as well. There's a big thing around unmet need. We know in Coventry, for example, we've got about 1,600 people out there who probably have COPD and we haven't diagnosed them yet. Now that's a big problem that we need to address, but we need to invest in services in order to be able to do that. a point that Jack alluded to, what if the benefits don't come until much later? So investment in smoking cessation is important, but I'm not going to see the benefits of that today. Investment in self-management is really important, but it's not going to save money today. And I have to manage the money today, I'm afraid. So that's tricky as well. What if the benefits of what we're doing don't actually fall within the NHS or social care? So we take money out of the NHS to invest in management of long-term conditions, and that's really good, and it improves people's health and well-being, and they're able to maybe contribute to the workforce and pay more taxes for longer. So that's an economic benefit, but that's not falling in the NHS. And the people, if you look at things globally on the wider scale of public services, you can see that starts to fit together. But if I'm the chief finance officer of an NHS organisation, telling me that benefits are going to fall into the wider population in 5 years' time doesn't allow me to take money out of my delivery, because that leaves me with a risk today. So you can see why it starts to become really difficult for the people who are making decisions about finances to make any move on this stuff, even though when you talk to people, they absolutely accept and believe in this. We're sort of paralyzed because we can't take those big risks. So it becomes really difficult to make those decisions. Next slide, please. There's also another point on that issue, which is fixed costs. So Jack looked at that whole pathway for COPD, for example, and we looked at, a lot of the spend on that big fat red triangle was in hospital admissions, and the other triangles, which might be around something like making sure that people have regular checks of their vision so they're not falling over in the first place. Low cost, high impact. What if we did need to take, 50, £100,000 out of the hospital budget so that we could invest in vision checks, which would be like a really good use of that money, because you could reach loads of people and stop them falling over in the first place. That seems like a really sensible thing to do. But they've still got to run the hospital, and big NHS and provider organisations have a lot of fixed costs like overheads and buildings and staff. It's not as simple as, okay, let's take money out. I'll get rid of some nurses and doctors. I'll close down a ward and then we'll spend the money over here, because that would seem like the economically sensible thing to do. But I'm running this hospital and I can't afford, if I close that ward, I'm just going to have to open it up for this other big list of people who are waiting to come in and fill that capacity. So the fixed costs aspect of this is a really, really big problem in the NHS that gets in the way of making these kind of decisions. So I've talked a lot about the challenges of making decisions, just to give a bit of context as to why, even though we know economically it makes more sense to invest upstream in preventative measures, which cost less sometimes, how difficult that is. But let's think then what we can actually do to try and give ourselves the tools and the information to be able to make those decisions in this new sort of commissioning and funding world that we find ourselves in. So there's a few tools, I think, that we can have at our disposal to sort of support this decision making. And the good news is that, speaking to analyst colleagues and public health colleagues around the patch, this capability does exist. There are colleagues out there with skills in health economics, predictive modelling, population health management, and we need to engage this capability when we are developing cases so that we can support more informed decision making. So, in the olden days, we used to, writing a business case meant, okay, figure out what resources you need to deliver more care and then ask somebody to pay for it. Okay, but that approach is no longer relevant. We need a much more sophisticated methodology that really evidences the costs and benefits of doing something and helps decision makers to feel more assured about taking short-term financial risks to realize longer benefits, because that's what we're talking about here. There is no additional funding. It's about taking a risk and you will get that return on investment in the future. That's the kind of world that we're in at the moment. So just looking at the elements here, predictive modeling is very important, because that tells me what's going to happen if I do nothing. So if we just leave things the way they are because we can't take the risk on investing more in COPD, for example, what's going to happen in 5, 10, 15 years time What do I know about my population in Coventry, for example? Who's at risk of developing COPD? What are those numbers going to look like in 5 years' time? What are the hospital admissions going to look like? What's the medication prescribing bill going to look like if we just do what we do at the moment? And we don't often do this in the NHS, but this is a skill that exists in some of our analyst colleagues have this skill. I think it's really important to bring that in. Understanding cost and benefits, that's health economics. Again, it's not a skill set that we regularly have in NHS providers, but it does exist out there, and we need to bring that skill set in. Population health management helps us to ensure that we're focusing in the right places, and we're addressing issues in our population that matter to manage that risk and opportunity. Again, those skills exist, and that's starting to come into how we do things in the NHS and social care. And then STAR is another new methodology to help us to understand the value of different interventions across the whole pathway. And I just want to reference something that my public health consultant colleague pointed me to, which is this data to decisions pathway. I've just got the top of the pyramid here. I'll share a link to this in the chat, but there's a load of data out there, and there are a lot of analysts out there, and there's a lot of public health professionals out there and economists. We need to bring the skill sets of those people together to help us to make decisions. So the way that we used to do business cases and cases for change to try and drive improvement, we need to bring that skill set and that sort of way of looking at things in, so we can make really good, well-rounded decisions. Bit of a call to action for colleagues out there, and I hope that there are many of you on this call who have these skill sets, to start thinking about how you can bring those to the fore and influence, not just influence, but kind of help us out here, because we don't know how to do this stuff. Actually, people like me, people who run NHS services, we don't actually know how to do this stuff, and we need your help. Okay, next slide, please, Jack. So now I'm just going to talk, just to round things up. I'm going to talk. Jodie's going to kill me for putting this picture here, but I just thought this quote was so good, because Jodie is one of our, Jodie really supported us with the STAR process in Coventry. And one of the absolute most brilliant things she did was she got 4 patients to come along who were all at different stages of their COPD illness. And that was such a powerful part of the process for us. So we were one of the first people to go through the STAR methodology in Coventry. And I just want to talk about some of the, okay, we're going to get a report, and it's going to tell us about the value of different interventions across that whole pathway of COPD in Coventry. And that's going to help to stimulate further conversation about where we should be focusing our efforts. But there was something about the process of going through STAR, some sort of benefits for that I just want to talk about, if there's anybody on the call who's thinking about going through the process. It's really powerful to get your stakeholders. So I'm not just talking about respiratory nurses, GPs, public health consultants. I'm talking also about local authority colleagues who lead on air pollution or heating or housing, and of course, patients. It's really powerful to get that group of people, everybody who has anything to do with COPD, in a room together to start to talk out loud about what they think adds value. Having to say out loud what you think the value of your intervention brings is a great opportunity. You know, if you've got people there from the voluntary sector, we've got a social enterprise who runs our pulmonary rehab, for example, bringing those people together in a room with the NHS specialist experts is a very powerful exercise. Very good for building a team of people who are focusing on the patient, and very good for educating people about all of the other things happening along that pathway that have a big impact on COPD care. So I highly recommend that approach. It was excellent. And we now can see ourselves as a team of people together focusing on delivering value in COPD. So, you know, whatever about the technical sides of this and the business case sides of it, that's a very powerful experience to have. Okay, so just to wrap up, final slide there, Jack. I think it's fair to say, from what I've said and what Jack and Richard have said, that decision making about funding, whether it's, you know, at an organizational level, place, or ICS, it's a complex business. The challenge now is about balancing risk, and we don't currently have the right approach to providing an evidence base to decision makers to feel assured we're making the right decisions, not just for our patients, but for the health economy. The STAR methodology is an attempt to articulate the value of interventions, and it facilitates a conversation about moving the money around, namely towards prevention and lower cost, higher value interventions. But we need to also back this up with a suite of sophisticated approaches so that we can develop a really robust and compelling case and feel confident that we're asking for the right things. So you're probably feeling a bit overwhelmed now, because what we've actually talked about is the challenges and there's lots of questions, but I think it's a good thing. I think this is a kind of cause for excitement, because it's a challenge to us to really look at how we make these decisions and what different bits of information, not just, you know, how we traditionally did this, but it's a new way of bringing together information to make good decisions about populations. And I'm hoping there are people in the audience who are thinking, I can help with this, I have those skills, I want to get involved in this. So I'm really interested to hear your views on that. And finally, I'd just like to say thank you to Andy and Sophie and Jack for their support throughout the programme. It's been a really, really great experience for us and we've learned a lot. So recommend it to anyone. Thank you.
Thank you, Leslie, for that, for your presentation. That was really interesting and definitely interesting to get the viewpoints from Richard, Jack, and you, Leslie, as well. So just to summarize, Richard talked about the sort of 6 key challenges, one being understanding the sort of citizens' voice and getting feedback from citizens. You talked about accountability and how you accelerate change as well. And then you mentioned something that I thought was really crucial, which is that the ICB is a sort of complex structure, and it's a new process for everyone. You know, that was also mentioned in the session earlier today by Amanda Sullivan and other chief executives at the ICB when they looked at what better decision making looks like. And one of the key things that I think comes from that session and this session is that you know, decision making it's a complex process with different decision holders, and they will have different priorities as well. And when we make these decisions, there are trade-offs between certain criteria, complex criteria. And I think you know, Jack's presentation on STAR kind of facilitates a large number of stakeholders and really simplifies in some way the kind of complex decision-making process, or maybe perhaps for want of a better word, makes it, you know, explores a sort of systematic way of making decisions. And Jack talked about this sort of socio-technical allocation of resources having 2 parts, the sort of socio part, which is the decision conferences. And again, I'm sure we'll have some questions on the challenges of decision conferences and perhaps Leslie's experience of that as well. And then you've got the technical bit to STAR, which is the sort of the math and the economics trying to work out sort of value for money. What was also really interesting is that both Richard and Jack talked about perhaps having a sort of single pathway. So the COPD pathway, for example, this is a portfolio pathway. I think that's definitely food for thought in terms of how we expand that sort of STAR process. And of course, finally, Leslie talked about her experience of population health management and the COPD model in Coventry with approximately 300,000 people. And then, you know, how we sort of try to achieve the 5 aims of PHM, you know, being health and well-being, including health inequalities and an enhanced experience. I think it's finally Leslie talked a lot about, you know, how do we incorporate those methodologies that Jack has sort of nicely sort of ran across not only in Coventry, but the 4 ICSs, and how do we sort of build better business cases using these sort of new methodologies as well. So at this point, I want to perhaps look to the audience for questions. So the first question here is, what steps would you take to ensure every partner within the ICS recognizes their responsibilities? around what we're trying to achieve in ICS.
Thanks. Yeah, a crucial question, really. And unlike, so we're behind Leslie as a system. We've done our pathway mapping, but I think you need to spend some preparatory time with the key executives, both sponsoring this and making sure that it's that there's buy-in from across your system, and that work and the work to get people all on the same page, that took quite a long time. So there was at least 2 or 3 meetings. There was kind of an introductory meeting, trying to appreciate the methodology, get to grips with it, understand what it will require in terms of participation, and a continual check back. So we have we've had a long existing COPD group, or a respiratory group, that have worked together pre-COVID actually for a long time and has had a strategy. So we had the basis of that group, but it was almost, you have to build over some sponsorship with that group, and that was done through taking it through the executive and the other partners. So we've never seemed to have had a problem in terms of wider integrated care partnership type participation. And of course, you're right, Wayne, it is a portfolio pathway. So there's some issues around air pollution, wider determinants, as well as living circumstances, right through to the specialist clinical end, if I can put it that way, through primary care. I think I would say that it feels like we're a test case, and that part of the learning is then to take that back out into our integrated care board, integrated care partnership, to kind of normalize it as a way of looking at allocative efficiency along particular pathways. But I suppose my short answer would be, you need to do the homework with the seniors right across your ICP. It might be useful to ask Leslie, because it was something I was thinking about. She was talking about, how you got that senior buy-in, because they don't really get involved in the actual pathway mapping, and the people who've done the pathway mapping, which is a bit that we've done, was this partnership team, and that was everyone's busy, so it was very well represented when we did it, and we did it online, which I thought which was very useful practically to get people involved from right across our system.
Sure. I wasn't sure with this question. Is it specific to the COPD STAR process, or is it a more general question around ICSs and partners in the ICS? I wasn't sure, because they're 2 very different questions. I'm not sure if we can get clarification on that.
Yeah, is that possible, Rakia? If we think about it from the sort of the work that you've done, that's in the COPD pathway.
So if you're talking about something specific like a COPD pathway, first of all, you have to understand who all the partners are across the pathway, and it's not just the usual suspects. Patients, absolutely, and different types of patients, because in Coventry, for example, we have a very diverse population. So putting the time in to think about getting representation from all of your different types of patients and their carers, especially with something like COPD, very, very important, right? So patients will tell you who the partners are, because they are the ones who are in the middle of this, who are interacting with all those different things. And you might be surprised by who some of the partners are, because they might not be your traditional NHS providers, for example. So you have to first of all do the engagement to understand who all the partners are, and think more widely than your own sphere of knowledge, I would say. People like specialist nurses who know their patients really well and have a long-term relationship with them will know those kinds of things. People who are involved in patient support groups. So you have to ask the questions and assemble your team. If you can, if you have some champions in there, they will do the work for you in terms of going out and engaging people in this and saying, you got to be part of this. And why would you not want to be part of this? Why would you not want to have your voice in something like this if you are a small voluntary sector organisation for supporting patients. If you are a social enterprise working in the sphere, if you're in the NHS, if your world is COPD, you will want to be part of this, and that's how you have to present it to people. And then, you know, do everything you can to make it as inclusive as possible and give people the best opportunity to be there. So, you know, I think knowing who to engage and asking the right questions and making sure that it's as a diverse group as possible is the best place to start with this, especially when this kind of work where you're trying to look at the whole pathway, and the pathway starts with smoking cessation. The pathway can start in schools, actually, if you really want to get into it, but it's not just about what happens once you get diagnosed with COPD. It goes much further back than that. I don't know if that answers that question, but
yeah, thanks, Leslie. I guess this feeds in nicely to some of the work that Jack has done on the decision conferences as well, and perhaps on question number 5 that's on screen now, or on some of the main challenges in setting up the decision conferences and getting the right people on board. Do you want to just say a bit on that then, Jack?
Yeah, definitely. And just to add to what Richard and Leslie have said too, the thing that you need first is resource and time and skill. They're not getting that level of buy-in is not something that sort of just happens. It takes a lot of time and resource. But yeah, main challenges of having a successful decision conference. Some we've touched on already. The first big one is getting the right people in the room in the first place. If the people aren't in the room, you can't get their opinions. We found, you know, as Richard said, we've gone through quite an extensive process of making sure people understand what they're doing and why we need their input and how it will be helpful to try and mitigate that, because if you don't get the people there, they can't give their opinion. What we found is actually once the people are in the room, you know, they quickly understand what's going on and why their input is valuable, which is really helpful. I think a big challenge too is dealing with power dynamics, which is why that sort of role of the impartial facilitator is very important. Everyone's grouped, you know, there will be, you know, the chair of the respiratory program on the board. There'll be a well-respected consultant physician who, you know, has worked in the area for ages. And there's a risk that what happens is they speak and no one else says anything else and everyone else just agrees. And you've got to make sure you manage that well. Otherwise, you know, they may well have very important views, but it's important that they don't overtake other people's views. One technique that that Fraser from the strategy unit, who I'm sure has done multiple talks as part of this festival, has given to try and mitigate this, is first get people to think about their views themselves and spend 5 minutes just jotting down notes, then discuss them in a sort of smaller group, and then bring them back to the whole group. And that way, you know, people have already formed their views before they hear what everyone else thinks, which I think can be really important. So yes, to summarize, first is getting everyone in the room in the first place. 2 is dealing with power dynamics.
Brilliant, thanks for that, Jack. On that point too, I believe both Richard and Leslie mentioned, you know, getting the citizen's voice or the patient involved in making these decisions. And Jack, I know you have done a lot of work on, you know, applying things like discrete choice experiments for understanding patient choices. I wonder what Leslie thought about that part of the project, and whether there was more we can do to get sort of patients involved in the decision-making process.
Yeah, I wanted to pick up on that. I think we were lucky in Coventry because we have some fantastic engaged colleagues. So Jodie, the lady whose picture I showed, our lead respiratory nurse, went to huge efforts. They, you know, the nurses were giving out forms to patients in clinic. They were calling up, you know, they went to huge effort to engage with patients in this program. Our discrete choice experiment, which Jack would explain better than me, but basically you're sort of asking patients to sort of say what they find is valuable for them. That was quite interesting, actually. But when you look at the demographics, brilliant response rate, but when you look at the demographics, it was white British predominantly, and we know that that's not representative of our population commentary. So I think that is a challenge that needs a different approach. I think the day that we had 2 conferences, which was sort of 2 half-day workshops in a hotel in Coventry. And it was absolutely brilliant experience. We really, really enjoyed it. I mean, we could have stayed there all day talking about, you know, how we all link up and how we join together. And I think if the patients felt like their voices were heard, they were a really great part of the conversations. I think they really enjoyed the experience. It gave them loads of insights, it gave us loads of insights. It was a fantastic experience. But you know, if I could say what could we have done better, I think representation of the diverse population is the next challenge on this.
Brilliant, thanks. Thanks, Joe. Sorry, was there a comment from Jack or Richard? I missed that.
Oh no, yes, I was just going to say on that point that Leslie said about the diversity of the study. What was interesting for me, it was probably evident to Leslie, was that the way we distributed the service was through existing healthcare providers. And when we presented that information, what we're hearing is, oh yes, that seems to be, we know that doesn't represent our wider population. That does represent the people who are interacting with the COPD services. And that led to lots of interesting discussions too. Yeah, sorry, Wayne.
No, that's okay. Thanks, Jack. I have one question, and you know, this goes out to the 3 of you. How do you think we can make, you know, Jack, you talked about STAR. We've got Leslie's experience of it as well, and Richard. How do you think we can make these sort of new tools or processes a bit more scalable? Do you think we can teach the ICSs or ICBs to run their own STAR programs?
I think Jack should go first.
Yeah, thank you, Leslie. I think the first one is that you know, hopefully Leslie and Richard and other colleagues involved in the program, by being involved, should be able to pick up skills that would allow them to run STAR or take on a larger role next time. We are also, I think it's January time, through the MDSN, going to be running a more in detailed training program on the STAR methodology. So keep an eye out for that.
Yeah, thanks. And then Leslie, then Richard.
Yeah, I think the idea is that we try it out, you teach us, we roll it out, we support each other, because, you know, there's a technical side to it, but we can learn that, or we can bring colleagues in to develop that skill set, and it becomes another tool in our arsenal of sort of making good decisions. STAR isn't everything, it's one part of helping you understand, and I think its real value will be in stimulating the conversation. We're not there yet, but there will be a time, I hope there will be a time where we'll be looking at public sector spending on the ground, and we'll be thinking about where to move money around or where to invest in. Maybe not moving money around, because that feels a bit hard right now, but where to invest in the future. And we'll need this kind of information to support those kind of conversations.
Thanks, Leslie. And Richard?
Yeah, I would say, I think for us it's early days, and I think we can learn a lot by going through the process and then learning how to do it. What I would say, I guess we'll still be targeting it at particular portfolio pathways for a while, trying to understand where we think we can have the biggest impact in terms of change. So, and that's a judgment call, isn't it? But I think we can. As Leslie says, it's one it's another tool in the toolbox, but it's one that, you know, brings in all the partners. So I think if you get it right, it would start a set of conversations that would cascade both up and down and right across the, you know, all our stakeholders, those who are providing services, involved in receiving services. I think for us, like Leslie, we have you know, we would want to make this inclusive through our diverse populations, depending on which pathway we're looking at. So that is a challenge that we've got, particularly the patient decision sort of side of it.
Brilliant, thanks, Richard. And as I've asked these questions, I realise I haven't been very systematic in going through the questions that are on the slide that's being shown now. So I wonder if we can very quickly, Jack, sort of address some of these here. So let's say question 3, Jack, what data underlies the triangles?
Brilliant. Very good question. So for the interventions that are based in healthcare, we use activity data, routinely collected activity data. For some of the services that lie in local authorities or voluntary sector, we've had to go directly to services and ask for those. The great thing about STAR is we don't need sort of patient level data. We just need aggregated data. So we've been using, you know, for pulmonary rehabilitation, how many people completed the course in a given financial year, which makes that a bit simpler. For the cost information, we've been in the first instance using contract values or the costs that would be incurred by the commissioner, so whether that's the local authority or integrated care system or other. And then for that number who benefit, that does change. So as part of this work, we've done a big literature review, and so there's some things where we've used evidence from the literature review to inform that. So an example would be the benefit of respiratory vaccinations. We've defined the COPD pathway. The people who benefit are those that don't have an acute exacerbation of COPD following their respiratory vaccinations. So that, yes, that's very broadly. One thing that we will say about STAR is what's important is magnitudes of difference. So it doesn't matter so much if something's 1 or 2 or 3, but whether something's 1 or 10 or 100 or 1,000. And that means you know, you don't need to have hyper precise estimates of everything, which can help in some of those where some of those gaps are. And I'm jumping around, but I've seen we've got a question from Jane in the chat about how do you attribute the health gain in the absence of published qualities? With risking taking up the whole session on this, we took an approach that was informed by qualities rather than directly using them, because as you say, there won't be data on qualities. Everyone, for those who don't know, qualities are quality adjusted life years, which is a generic measure of health gain used in lots of different areas of health economics. We used something called the visual analog scale to assess the relative benefit of all of the interventions in the given pathway, was the way we did it. And I'll see if I can find a link to post in the chat of an example.
Brilliant, thanks, Jack. So I do realise quite a few questions here around the technical aspects of STAR and how you apply it. So perhaps, Jack, if we could exchange or share an email if you're happy with that, and then we can respond to some of these that we don't get time to address directly or share some of the responses via a sort of email list, and we try and work that out. Is there, let's just see if there's any other questions on there. Any plans to target geographical communities or different cultural populations? I wonder if you can talk a little bit about how you, again, this is possibly sort of the public and patient experience and around kind of making sure that we have a representative sample of the public or patients during parts such as the discrete choice experiments, but any other sort of methods for ensuring that we include other, different populations? Leslie, I think you've had your hand up.
Yeah, I think this is a question which is wider than STAR, isn't it? This is a question about how we ensure as ICSs or places or whatever organizational structure we're in, that we are engaging with all parts of our community, because actually the people who are more vulnerable are the ones who, we probably need to be focusing on the most. And somebody put something in the chat saying, I feel another triangle coming on. Oh yeah. Actually, if you looked at, the value of intervening with people who are most vulnerable, who aren't accessing healthcare, aren't looking after their health, don't know how to access their services, only find out about them when they pitch up to A&E with stage 4 lung cancer. Yeah, we could probably think about where we're adding value for those people. So absolutely. And, as Richard said at the beginning, part of the mandate or the objectives for ICS is to address health inequalities. And to me, you cannot do that without targeting specific communities, people who are, impacted by the wider determinants of health, etc. And how do you even know that? Well, you need to know something about how to engage with communities as well. So all of this stuff sort of goes together with, how do you know that you're focusing on the right things? How do you know where to focus your priorities? You need to engage with people. You need to use insights and intelligence. Okay, so we're into population health management. That helps you to focus where you need to go. This other part of the conversation today is about how do you really understand the value of all the different things that you need to do, so you have some sort of an idea about where to invest funding. So the first part of that is, where are you focusing, and who in your population needs you the most, and what kind of things do they need from you? Those things are diverse. Okay. The other part of it then is, okay, so we know all these things that we need to do. We need to spend money on them. How do we know that we're spending money in the most cost-effective way? So it all goes together as part of a big jigsaw. It's, slightly challenging that we're starting to figure out all of that stuff at the same time: population health management, community engagement, and understanding the value of investment, all at the same time. But actually they all fit together perfectly, don't they? So, maybe in 5 years, definitely 10 years time, we might have a handle on this, but this is early days, isn't it? But it's wonderful that we're having these kind of conversations, because we weren't talking like this 2-3 years ago.
Yeah.
I don't know if Richard has, Richard probably has a more ICS, ICB view on that.
Yeah, thanks, Leslie. As you were talking, I'm thinking spot on, really. I think we are just beginning to ask the right questions. I don't, but I wouldn't profess to say, in our ICB, in our integrated care partnership, that we've got the right answers. We're still building the kind of infrastructure and the analytical capability. I think there's some momentum that we've got to pick up community engagement. Someone asked a question about place. Our place is still to be really set up in terms of how they're going to operate across in Birmingham and across Solihull. So there's quite a bit of work to do as we make that transition. And I think it's at that point, whether it's at that level, and as we've mentioned, localities and primary care networks, that we begin to get a lot more granular geographically in the populations that we've got. But yeah, those are exactly the right questions. and this is one aspect of you know, a toolbox that we hope to develop. I think the other one is population health management. But I think, as I described in our system, at the same time as taking a system view for some things, we want to devolve down to a place or an integrator. So bringing those alongside of us is really important. Thanks.
Brilliant, thanks for that, Richard. Jack, you've got your hand up.
Thanks, Red. Yeah, I actually had a question for Richard. You may tell me this isn't for public consumption, so that's fine. But you mentioned that you had a Fairer Futures fund, and there was a prioritization process that you went through to sort of allocate the money out in that fund. I would be interested to hear more about how you do that prioritization, and bearing in mind you haven't been through the STAR process yet, you know, how it compares and contrasts.
So yeah, it was interesting. So as we were just before we kicked off STAR, we had a respiratory strategy day, and someone came to talk about health inequalities and talked about the Fairer Futures Fund, which is community based. The short answer is I think it's still untested. The prioritization process, though, we've had built on what the combined CCG used to look at. I think it's a modified Portsmouth. I think that's a technical way that to describe it, with a kind of continuous overlay to try and get the value set right, with a so it's a scoring system. I think most colleagues will be aware of there are different scoring systems. It's just one we've adopted, but it needs constant, and we've had to kind of renew the value set that lies behind the scoring system. So that's being currently used, but it's not the only thing that we use. Actually, it kind of gives you some information, but not all of the information. And I made the comment around we don't yet have the equivalent of the commissioning round where you can take an overview. What we've got is a set of things popping up that need to be funded. And as we've been discussing about this, you know, we've got we need some headroom even at the system level, because we're still fighting the headwinds of extreme acute pressures, which I think you're seeing up and down the NHS. So part of the story with this, and I think the way we hope to use it, is to get yeah, someone's put a link, thank you, is to get the ICS into a place where it can begin to think about the longer term consequences of the funding decisions, both within pathways and between pathways. But as I say, we've only just started the journey. And as far as I know, I haven't seen any projects come through the Fairer Futures Fund. It's been announced. You can follow the detail. It looked very interesting. I will check and see what kind of prioritization process is going to be used. If you read the ground rules on it, though, it is meant to be easily accessible to pump prime change at a community level. So there's some risk in there, isn't there? A risk that actually probably we're not, you know, we're still going to get comfortable to take.
Thank you. That's really interesting.
So Richard, you mentioned the specialized services. So I wonder if you could talk a bit around how that fits into the ICS model, and whether you think approaches like STAR can be applied to decision making in that sector.
Yeah, I would just say as part of the portfolio, we, you know, as I say, there's going to be a shadow year from next year, working towards beginning to take on, probably in a shared way, I think, across the West Midlands, the budget, but at least having an involvement in specialised services. I mean, in effect, some of what they do is at the table, some of it isn't, particularly because of the respiratory work that we have. But I guess it will be really interesting to add it into the full pathway. across some other pathways where there are significant spend, which we've never had to consider before. Not in terms of a commissioning approach and a prioritisation approach anyway, because it's always been done through NHS England. So yeah, I think we're gonna have to watch this space. I don't know quite how it's going to work, but we will be closer to what we are spending on our population in terms of specialised services, beginning with particular specialised services, and then I suspect opening out. So renal is an example. The specialised services around renal spend is still separate from what we do, and so bringing it in has challenges from a kind of long-term conditions management point of view, but also from a beginning to think about spend across a pathway point of view. So again, we're going to have to test this out. I haven't got an answer for you particularly, but it will be an additional factor to think about.
Great, thanks Richard for that. At this point, I wonder if you want to sort of reach out to just to cover if there are any more sort of final questions. I know there's question 11 and 12 that's shown here to Leslie.
Yeah, so there's a question about fixed costs. Surely then you need to ring fence money for prevention. It depends on what you're talking about. So if you have a budget of, let's say, about £20 million for all of the COPD pathway in Coventry, give or take, right? And that's all allocated to various providers along the pathway: primary care, community teams, patient support, hospital outpatients, community COPD team, everything that makes that up. If I now need to do something additional, actually I want to spend more money on smoking cessation, or I want to really expand patient support groups because they're really high value, where am I going to get the money from to do that? Because there's no available funding. So the only way for me to improve or expand anything is to take money away from somewhere else. That's what the point I'm making at fixed cost there. It's very hard to take money out of something and put it into something else without disinvesting in a service. So it's in that world of there is no additional funding, but we're trying to do more with what we have. That kind of challenge is very difficult. When you're in the realm of there's new money from NHS England, or there's new money through a community fund, or there's new money through Fairer Futures, or any other possible way that we can access funding, then you can start to use these approaches beautifully, because you can reassure yourself that you're not just saying, let's get more beds in the hospital and deal with the big waiting list of people. You're actually saying it might make more sense actually if we use that additional funding to focus on prevention. Or actually, do you know what? Patient support groups don't cost a lot, but they have a massive impact on how well patients are. Maybe we should prioritize spending there. So there's two different scenarios there. When I talk about fixed costs, I hope that makes sense. The next question is, I think it's more a statement, which I agree with. Just on that statement, so there's a kind of point around, there's no money to do this. I don't know. I mean, we have to find a way to engage with communities, and it might not be that we, the NHS, are the people that need to do that. Maybe we need to work with community and voluntary groups to do that engagement for us and fund them to do it, because actually they'll do a much better job and they understand their communities better than we do. So I think that has to be the way forward when it comes to community engagement. There not being money to do it at the moment is not a good enough reason not to start trying to do it. We have to find a way to make that of value and influence that happening, whether it's on a, in Coventry, for example, we're going to start very small with that and align it to a program of transformation around the older people's pathway. We have to start doing something on that to show the value of it, and then that kind of gains momentum. So I think, if it doesn't feel like that's valued because there isn't funding available to do it, don't be put off by that. Find a way to make it happen on a small scale. Work with the community and voluntary sector. Let them lead you on this, and then see where you get to. but we absolutely have to do this. It's fundamental to population health management. It's fundamental to everything that we do. Please don't ask me to explain what population health management, like, there's got to be like a public health person in the audience who will take that one on, because STAR is different to PHM, but I'm not answering that. Somebody else can do that.
I can have a go, but I'm sure I'm going to offend many PHM colleagues on the call. So yeah, as I said, it can be used as part of the cycle in PHM. So, you know, once you've done your population segmentation, you've done your impactability modeling, you've worked out where you need to focus your energy, you still need a way of working out of everything you could do to meet that priority. What is it you can do? So STAR can be used as a tool to help set priorities, determine what you do to focus on your whatever issue is identified in the cycle. I hope that makes sense.
Brilliant. Thank you, Jack, for that description. I wonder if at this point, I can't see any more sort of questions coming through, but if we can, I'd like to sort of open it up to sort of final comments from the panel. Should we start with Richard?
Yeah, thanks, Wayne. Yeah, so I think that it's a great technique. I think with the right sponsorship and participation, you know, across the pathway, and particularly with, you know, we've talked quite a bit, which is I found very thought-provoking, really, about how we involve communities, particularly in the decision support conferences. So when we're setting that up, I guess we've got an opportunity to learn from Leslie in Coventry, because they're ahead. So I think again, the work on how you set this up is crucial, as always, as well as how you manage it while you're doing so. But I think that it'll help raise some of the questions that I referred to earlier around the challenges. So going through the process once for one pathway will help us have the debate, I think, across the ICS, within the ICB, about this notion of moving. Can we move? Do we have an appetite to move resources around to that extent? And if not, can we at least look at resources within pathways or the next, you know, best buy, and particularly around the wider determinants, because that's going to be really crucial. I remember talking to Andy about this, and we were talking about perhaps we should be spending money on boilers rather than more hospital admissions. Not, you know, not easy to say, not hard to do, because how do you turn off the tap? But conceptually, I think we could start to have those debates, and I would expect this will work both for the group within the pathway, the respiratory partnership, to understand their own pathway and bring in a wider view, but also above that level within the ICS and the ICB. So I think it'll help raise the right questions that we then have to come up and start thinking about techniques to answer.
Thank you, Richard. And then to you, Leslie, and then Jack.
I'm really interested to hear what people think about this session, because you might potentially come away from this feeling a bit sort of frustrated or overwhelmed that, you know, I came here to learn about how to make decisions, and actually what you've told me about is how difficult it is to make decisions. But actually, I think that is the reality of where we are. But what's really positive is that we're starting to challenge ourselves to look at things in a different way. And it's very heartening that quite a lot of the comments on this meeting were about patient engagement, isn't it? Because that actually shows that we really are trying to look in the right places to answer some of these questions. So that's a good sign. But I think, you know, when we talk about population health management, when we talk about things like STAR, and we talk about even the new structures in the NHS and social care, there's a lot of uncertainty at the moment. But taking the time to have conversations like this and to really start thinking and challenging ourselves. This is what we have to do now, because if I want to get money for my new COPD pathway that I really believe will improve health and well-being for patients, I'm going to have to get smarter, and I'm going to have to get some better information. So the next time I go back with my business case, they might be able to say yes to me, because at the moment, nobody's able to say yes to me. And that's the reality. So, you know, I hope that, although it might be a bit overwhelming, people also feel a bit kind of fired up that, okay, we've got to grapple with this and find a better way to kind of move things on.
Brilliant. Thanks, Leslie. And I agree with that. You know, these decisions are complex decisions, right? Healthcare and resource allocation is complex. But once we find the right tools to support those decisions, and I think STAR being one of them, then hopefully that can facilitate these decisions in a much better way. And a lot of these decision techniques, but whether it's on a sort of meso or macro level, have been complex anyway. Hopefully we've also got a good team, and a good team of health economists and analysts and population health analysts that can support these decisions as well. And finally, Jack.
Thank you, Wayne. My first, I've got two final points. The first is just to say to Leslie and Richard, thank you so much for coming. It's been a pleasure working with you both over the Leslie, I think it was this time last year we first spoke about this, so been an absolute pleasure. And my second comment is a shameless plug. We're the Health Economics Unit at the start of thinking about this program for next financial year. So if anyone is interested in getting involved and finding out more, drop me an email.
Brilliant. Thank you, Jack.
For the what program? So sorry, Jack, what program are you talking about?
Oh, so the program in which the STAR program. Yes.
Oh, right. Okay. Okay. Thank you.
No worries.
Brilliant. Thank you, Jack, for that. I just want to say thank you so much for the panel and your amazing insights. Thanks, Richard, Leslie, and Jack. It's been really, really insightful. Really good to have you on and presenting your views on decision making in the ICS. You know, in terms of on behalf of Health Economics Unit as well, if there's anything that you want to find out, I'm going to direct you to Jack, who's amazingly sort of ran the program, as I said, across the sort of 4 ICSs and Coventry Police as well. And as Jack says, we're hoping to kind of expand on that in the next year or so. I hope I'm saying this right. We haven't got all of the outputs from the ICSs yet, so we watch this space, and we're hoping to get some really amazing feedback from Leslie and Richard and how it went, and being part of the program for STAR on COPD. So once again, thank you very much, Richard, Leslie, and Jack.
Thank you too, Wayne.
Thank you.
Thank you.
Bye.
Brilliant. Thank you. And just here are the sort of final upcoming events on the 30th of November. We've got on day 8, how can you be evidently better when making decisions? You've got Sarah Jane, insights from decision-making practice. And then on day 9, we've got Sir David Dalton, how do you get the desired results from your decision-making? So please register. I'm sure they'll be very, very interesting sessions as well. So please click on the link to register if you're interested in hearing what they've got to say. Brilliant. Have a good afternoon and speak to you soon. Bye-bye.